everyone, and welcome to today's Public Health Ontario's Microbiology's Rounds presentation on preventing childhood asthma, the neglected impacts of antibiotic stewardship, and human milk exposure in infants. My name is Kevin Schwartz. I'm an infectious disease physician with Public Health Ontario, and I have the pleasure of moderating today's session. Before I begin, I want to mention a few housekeeping items. The chat pod has been disabled to limit any distraction during the presentation. Please use the Q&A pod if you have any questions during this session. A discussion and question period will follow the presentation. If at any point during this session you experience any technical issues, please email capacitybuilding@oahpp.ca. I would like to state, as the moderator of this session, I have no conflicts of interest. It is now my pleasure to introduce the speaker for today's presentation, Dr. David Patrick. Dr. Patrick is an infectious diseases specialist and epidemiologist with a career interest in responding to emerging infectious diseases. He is a professor in the School of Population and Public Health at UBC and has also served as director there, as well as a research director at the British Columbia Centre for Disease Control. He has published over 250 papers and books on topics ranging from HIV to COVID-19. His main research focuses on containing the threat of antimicrobial resistance and understanding the connection between antibiotic use and atopic disease at the population level. It is my sincere pleasure to now pass it over to Dr. Patrick to begin his presentation.
Thank you, Dr. Schwartz. It's really nice to be talking to Ontario colleagues on this topic. You'll notice that the title is a little provocative, and it's intended that way in order to get some discussion going. We want people with different backgrounds and different knowledge sets to attack this question from different angles. I'd like to also acknowledge the fact that a lot of the work I'll talk about here on population-based cohorts in Manitoba and BC was led by Hannah Lishman, who is now a senior scientist at the BC Centre for Disease Control. So I sort of put her down as a co-author on these related talks. We at UBC and the British Columbia Centre for Disease Control are on the unceded territories of Coast Salish-speaking peoples, Musqueam, Squamish, and Tsleil-Waututh. And I know throughout Ontario, you are on the territories of many diverse First Nations. I did post the objectives with the talk, so I won't go through them in excruciating detail here, but we do need to sort of acknowledge that there are existing changes in the epidemiology of childhood asthma that are observable around the world, and that we're in the process of trying to draw the link between those changes and what we're learning about the importance of the developing gut microbiota and its impact on the developing immune system. And so for the purposes of this study, I'll be drawing from the literature. I'll be talking about published work from the Canadian Healthy Infant Longitudinal Development Study, and I'll be showing you some of this population-based birth cohort work we've done out west. So I don't have conflicts of interest on this. The work that we'll be talking about here was funded through CIHR and the Pacific Foundation for Public Health. And I'll give you a bit more on study-specific disclaimers from the population studies in a moment. I want to also acknowledge that this whole field is a team effort. The folks on the left-hand side there are involved in the grants and papers on the population-based cohort, and they include Hannah, but also Megan Azad and Stuart Turvey from the child study. And I also want to acknowledge, especially being here in Toronto, that the child study is led to a large degree from Toronto, and you have Professors Subarao and Moraes and others who've made active contributions from that study right here at U of T. So let's start with the thesis. We know that the prenatal period and early infancy is a key period for the development of the immune system. Clearly, that is influenced by genetics. It is influenced by host biology, and very much it's influenced by environment. Now, a neglected part of that environment for a long time, not so much in recent years, has been the trillions of bacteria and other organisms that make up the gut microbiota. They're a key element of that environment, and they themselves may be changed by diet, environment, and medical interventions, especially antibiotics that kill them. So the microbiota are known now to interact with and train the developing immune system. I'll talk you through on a very high level what we know about that. And so perturbation of that development by antibiotics may predispose to abnormal immune system development and a higher risk of atopic disease. So not just asthma, but also things like hay fever and food allergy and atopic eczema. And what we're saying is that at the population level, as public health scientists, we think that that may explain some of the population level trends that we're seeing today. That's the thesis. Now, in advancing this, it's probably also important that we recognize that Mark Twain said, to a man with a hammer, everything looks like a nail. And Dr. Schwartz and I are infectious disease specialists, so naturally our eyes turn to what's going on with antibiotics and antibiotic use. Although this time we want to use the claw end of the hammer to pry out the nail rather than hammer it in. But if you think that the claims that these things may be related are extraordinary, as Carl Sagan would say, extraordinary claims require extraordinary evidence. So we want to talk you through the population studies, the prospective cohort studies, the studies of the gut microbiota and atopic outcomes, and experimental studies that might support that hypothesis. So before starting, there are some sensitivities that are really important to acknowledge. First of all, antibiotics are often needed in the first year of life to save a life or to cure a severe infection, and we're not trying to stigmatize anyone who needs to use them. Similarly, breastfeeding is pretty loaded. It's a very gendered construct. There are women, but other people who would like to provide human milk to their children. We've also got the context of the fact that breastfeeding is not easy for some people, and we don't want to stigmatize people who are unable to do it. So we need to unconditionally support people having problems in these areas. So first of all, the next two slides are from a review in Nature reviews that really summarize what we know about microbiota in early childhood. And what goes on here with this red line going up is that right after birth, the initial bacteria inside a baby are from the mom. They're recognizable gram negatives that came down from the vagina and the GI tract of the mother. But then not long after, you see this green peak, this bifidobacterium peak, and bifidobacterium blooms in response to oligosaccharides that are uniquely there in human milk. Interestingly enough, they don't feed the baby. What they do is they seem to feed these bacteria and allow a peak. As weaning begins, you see this other blue line come in, and you see Clostridia bloom, and these are importantly environmentally derived fermenting organisms that ferment fiber really down to short chain fatty acids. And so both the bifidobacterium and the Clostridia produce short chain fatty acids, and those in turn are known to stimulate Treg cells and Th1 development. So what can go wrong with that process? Well, you can have in utero exposures. You can have preterm birth, cesarean delivery. You can have formula feeding, which is absent those key human milk oligosaccharides. And you could have antibiotics in the first 6 months of life. And that can lead to an increase in proteobacteria, so that the maternal flora, or premature diversification where you've lost that bifidobacterium peak and the short chain fatty acid production that goes along with it. In the second 6 months of life, you can have disruption by antibiotics or a lack of environmental exposure, and you can lose the fermenting Clostridia species that also produce short chain fatty acids. The net result, if you don't get that normal development, will be more Th2 and atopic responses and less Th1 and Treg responses. So what does the literature show about exposure to antibiotics and atopic disease? So I wanted to point to this review by Duong and Zimmerman out of Switzerland, where they took a look at 51 studies and created a meta-analysis. And to make a long story short on the asthma side, you're really seeing 2 times the odds of developing asthma in children who are exposed to antibiotics in the first year of life. So asthma in childhood, 2 times the risk if you're exposed in early life. But not only that, you're seeing significantly higher odds of developing other allergic diseases, which are felt to follow a similar immunological pathway. And so there's your allergic rhinoconjunctivitis or hay fever. There's your food allergy, and there's your atopic dermatitis in there. Further, these studies would show a pattern that the earlier in infancy you're exposed to antibiotics, the higher the risk associated with them. And that may fit to a certain extent with what's going on with the microbiota. So that's the overall literature. Here in Canada, many of you will be aware of the Canadian Healthy Infant Longitudinal Development Study, and we published on this topic back in 2020, and there's more great work happening out of Dr. Sabara's lab today as we speak. But this is a 4-city Canadian birth cohort that has followed children up from birth to they're just about hitting puberty at this stage in the game. And what they do is if they're able to assess what's going on with the mom from before birth and on at various different intervals. They're able to assess what's going on in the environment of the child, which might include exposure to antibiotics, indoor smoke, and they're also able to use area level pollution estimates from the canoe study to sort of talk about the impact of environmental pollution as well. So that's sort of a description of the study. The analysis we did and published in Lancet Respiratory Medicine in 2020 was an analysis of just over 2,600 kids who had been followed up to 5 years at that point, as well as a subsample of them of about 1,000 who had microbiota collected. And just to go back to the previous slide, the real gold in this whole collection here turns out to be these nappies at 3 months and 12 months, which represent the poop specimens from that cohort. And as we speak, a much larger proportion of the cohort is having their poop analyzed. So that's what went into this study. And what we basically found in following up that study is after adjusting for covariates, the adjusted odds ratio for outpatient antibiotic exposure before age 1 was 2.5, so 2.5 times the risk for developing asthma. But we were worried a priori about confounding by indication. In other words, could it be the lower respiratory infections that triggered those antibiotic prescriptions that really caused the problem? So our main analysis in that study excluded the kids who received antibiotics for those lower respiratory infection symptoms. And what we still found was an odds very much in that Duong-Zimmerman range of double, 2.15. And so that's fairly significant. And this is taking into account in the adjusted analysis other variables that are obviously known to be important, including exposure to tobacco smoke, pollution, including ethnicity of the child, sex of the child, because males tend to get asthma earlier in earlier childhood. So it's still a significant odds. Moreover, there was a dose response in evidence. And so if you had no exposure to antibiotics, you had about a 5% risk of getting asthma by age 5. But if you had a 3 or more courses, you're up to almost 18%. The other thing is this study, we did a high-level look at the microbiota using 16S methodology, and we'll tell you a bit later about why metagenomics adds even more to that picture. But with the 16S methodology, we were able to see that diversity by 2 well-established measures of the gut microbiota at the age of 1 was less in kids who would go on later to develop asthma before the age of 5. So less diverse microbiota is statistically significantly correlated with risk of asthma. In fact, if you decide to put diversity into the model rather than antibiotic exposure, although the effect seems small in this little area here where you're talking about chow, what that means is for every interquartile increase in diversity at age 1, you're seeing a 32% reduction in risk of asthma. So not trivial, and that's taking into account those other important variables. In that study, we also did a preliminary attempt to identify what these key bacterial species or taxa were that might be important. And we did that by looking at differential expression in kids who'd had antibiotics and as well as in the kids who went on to develop asthma. And sort of this area where everything overlaps in the Venn diagram, those 6 taxa in the middle are represented over on the right. And what's interesting about them, if you're a microbiologist, is that they are among the usual suspects. These are fermenting organisms that produce butyrate in the second 6 months of life, and that's thought to be a mechanism of skewing the immune system away from atopic responses. Now, within the study, you could easily ask the question, couldn't it just be a direct effect of the antibiotics somehow causing the problem, or does it have to be mediated through these changes to the gut microbiota? So we did some structural equation modeling, some mediation modeling, where we looked at the adjusted covariates and got an estimate of the probability. And to make a long story short here, the indirect effect via the gut microbiota was a more probable explanation. And there's similar work going on in the Toronto lab now, taking a look at the interaction between infections and antibiotics. The other thing that came out next was a paper that really took a close look at human milk exposure and asthma risk. And if you take a look at the overall literature, as some of you will know, it's hardly a clear-cut story. There have been cluster randomized trials of breastfeeding promotion that have shown no clear benefit for atopic disease or other outcomes. So it's not slam dunk. But what we did was we thought we needed to take a look at this in terms of interaction with antibiotics. And so what this analysis shows is that for children who were exposed to antibiotics who were not breastfed, they had not twice the risk, but 3.5 times the risk of developing asthma. But by contrast, those children who were breastfed, even if they were exposed to antibiotics, had only a 30% increase in risk, and that wasn't statistically significant. So what this is telling you epidemiologically is it looks like breastfeeding is mitigating the risk associated with antibiotics. But then if you take full metagenomics, you take a look at the full sequence of what's in that poop, it gives you better species resolution than what we were able to get from 16 sRNA in the previous study. And what we find is that compared to infants who received antibiotics without breastfeeding, the presence of breastfeeding during antibiotic exposure actually increases species richness closer to non-antibiotic levels, actually sort of rescues many of the impacted species. And a very important part of the story is that Bifidobacterium longum has a variety of subspecies. The subspecies infantis is famous for its metabolism of human milk oligosaccharides into acetate. And so B. longum subspecies infantis enrichment during antibiotic exposure seemed to be a key mechanism. So let's just summarize that in simple terms. It means if you have exposure on the top left, infant antibiotic exposure without breastfeeding, you have reduced or absent B. longum subspecies infantis colonization, and you have 3 times the increased childhood asthma risk. If on the other hand, you work from the bottom right, you have antibiotic exposure within the first year, but you are being breastfed, those human milk oligosaccharides support the population of B. infantis and provide some protection from that elevated asthma risk. Those were the conclusions of that study. Now, some of our colleagues in the study also went a little further to look at this overall relationship in delayed diversification and of the gut microbiota, and found across the board that it was associated not just with asthma, but with atopic dermatitis, with food allergy, and with allergic rhinitis. And that makes sense if you believe that maybe we have an immunological mechanism of the connection between antibiotic exposure and asthma risk. So what's happening around the world? A paper came out in England early last year, which is one reason I went there for a visit in the spring. And they're showing that their asthma rates have fallen by about half over the course of 10 years. Take a look at the red line in terms of the incidence rate at the top, and you can also see that prevalence is falling in younger children. And that's not trivial. That fall in incidence among 1 to 5-year-olds translates to 10,000 fewer asthma cases in an English birth cohort of 600,000 each year. And interesting thing is we recently got a hold of some of the Canadian Chronic Disease Surveillance System data. Some of you probably know those data better than I. And if you take a look at incidence or prevalence in 1 to 5 or 5 to 9-year-olds in Canada, we've seen a similar halving of the burden from asthma. We don't talk about that much because usually when we're talking about asthma epidemiology, we're talking about age-adjusted prevalence. So let's talk then about these effects we're seeing in cohort studies like child and what we might expect them to be doing in a population over time. One tool for this is the concept of population attributable risk. And as many of you know, this can be explained as the potential reduction in incidence or prevalence that would be observed if a specific exposure were eliminated from the population. And it can be calculated if you know the proportion of your population exposed, which we do with antibiotics, and the relative risk. And then we also ask the secondary question, how might the combination of decreased exposure to the antibiotic, but also a falling relative risk because of increased breastfeeding affect asthma incidence? So the next couple of slides are a little bit of modeling around that we will compare with reality. So this is BC in the year 2000. We had an incidence of asthma in children 1 to 5 of 28 per thousand. And at the time, about 2/3 of the babies were exposed to antibiotics, and maybe 45% of them were breastfed to 6 months, according to the CCHS regional data. And so if you sort of take into account the fact that, the kids who are not breastfed have the higher relative risk and those who have a lower one, and you do it proportionally, that gives you a blended relative risk of 2.5. Now, if you put that into your equation, it sounds huge, but we're talking about maybe half of the asthma burden there being somehow attributable to that. Now, you could come up with a lower estimate if you plugged in lower relative risks and that sort of thing. This is just for demonstration purposes. But could it be that in 2000, 50% of our burden of disease was associated with those factors? Fast forward to 2018, and in British Columbia, the proportion of babies exposed to antibiotics had plummeted, and it was down to 28% of infants under the age of 1 who received an antibiotic. Now, if we imagined that breastfeeding didn't change and it was still 45% to 6 months and we still had the same relative risk, we would predict that that would drop the contribution of antibiotics from 50% to 30%, which would be a pretty good change, and predict a fall to about 22.2. But if you take into account that breastfeeding also changed, we had an increase in breastfeeding from 45 to 70%, up to 6 months. So falling antibiotic use, increasing breastfeeding uptake, a falling relative risk as a result. You'd go from 50 to maybe 21%, and you'd predict an incidence of 19.8 per thousand. So a fall from 28 to 20 per thousand. What we actually saw in the BC data was this. We saw here's the falling rate of antibiotic prescription with the blue line. The actual observed asthma incidence in the red line fell pretty dramatically and in parallel to the falling rate of antibiotic use in babies. And that prediction of, just under 20 asthma incidence is there in the blue bar. So reality is pretty close to the prediction. But of course, there's plenty of room for other important factors to be playing a role here, changes in indoor smoking, changes in air pollution, and changes in infection exposure. So what we're saying is that at the population level, the effect size that has been measured in cohort studies from declining antibiotic use and increasing breastfeeding are on a scale that could at least explain some of the dramatic observed reductions in incidence of asthma that we've seen in children and resulting fall in prevalence. So we're working with the English to sort of see if we can draw that correlation on the English data. The Germans have already done it and published a correlation there. But let's talk about this also from the point of view ecological studies. It's nice that they can provide a correlation of asthma with declining infant antibiotic use, prediction of incidence in small geographic areas like we've been able to do in BC. They can show a strength of association between antibiotic exposure and asthma risk that may be changing over time with breastfeeding. But let's talk about those limits of ecological studies. We can have other risk factors that maybe are not being measured, and in particular, confounding by indication. So what if respiratory infections that drive antibiotic use themselves cause the asthma and the antibiotic use is somehow incidental? Reverse causation is important too. What if a declining asthma epidemic is resulting in fewer antibiotics being prescribed? You have less kids with scary wheeze in the first year of life. So for that, you need to do a study at the individual level, but in large populations so that you have the sample size to interrogate some of these questions in sensitivity analyses. And that is why we turned to studying the birth cohorts in the 2 Canadian provinces where we could get accurate estimates of on an individual level of antibiotic exposure in infancy. So that was BC and Manitoba. So what we're doing is we looked at the entire birth cohorts of both provinces over a 10-year period from 2001 to 2011. We followed those kids up to age 7 to ascertain whether they had asthma. And we also had a parental look-back period for 5 years before the kid was born to get any indication of atopic predisposition in the parents. The exposure was antibiotic exposure by the first birthday. And the outcomes were atopic outcomes, asthma, eczema, or hay fever by the 5th birthday. And of course, as with the cohort studies, we're dealing with multivariable logistic regression and clustering standard errors on the mother's ID to help minimize some unmeasured confounding in the home. So I'm putting up these additional disclaimers here just to let you know that the data that we worked with were from Population Data BC and from the Manitoba Centre for Health Policy. And they gave us the blessing on doing the research, but had absolutely nothing to do with the findings. And our findings are not the opinions of the data stewards. And for those of you who are interested, who look at multiple data sets, these are how the data sets lined up in BC and Manitoba and what their sources were. And so you can well imagine it was a fairly complex undertaking to get the data assembled in the first place. And anybody who wants to talk about that offline, we can do that. So in the end, though, what does this mean? It meant we had covariates for the mom. We knew her age, her BMI, her smoking, alcohol, drug use, prenatal and intrapartum antibiotic use, so we could balance that against postpartum use, her diabetes, parental history of atopic responses, and we had atopic responses for the dad, too. In terms of the kid, we knew about mode of delivery, sex, a whole bunch of other things that were important, and the likelihood of human milk exposure in that child. And we also had those all-important very fine in area level environmental measures from the canoe study. Now, there are limitations when you take a look at an administrative cohort like this, and I want to name a few. Some is that, you're not going to jump on atopic eczema and hay fever diagnoses by the age of 5 very often. Things are going to be managed with over-the-counter medications and creams, and so you'll have relatively few diagnoses there. Asthma ascertainment is a little better. There's also a potential for misclassification of asthma because and the impact of that, and in contrast to the clinician phenotyping that you see in the cohort studies, the implication of that would be that you'll see reduced strength of association. You'd still expect associations to be in the same direction, but misclassification will create a conservative bias in the effect estimates. And then we don't have data for everything in our theoretical framework, and we're only capturing, community prescribing, but that is the vast majority. So I like to call this the confusogram, and it's just to show actually our respect for the complexity of causation of asthma. But the easiest way to follow it is from near the bottom left. You see baby antibiotics in the first year, and we are obviously thinking that's moving to the right, influencing the baby microbiome, further to the right, creating pro-allergic immune skewing, and reading to allergy outcomes over in that blue box with the horizontal line. But there's lots of other things at play. And so it is important to recognize that while a dag in the southern hemisphere, if you're a shepherd, is a piece of poop hanging off the back of a sheep, a directed acyclic graph is, of course, a means of us thinking about the mechanistic pathway and helping us establish if any biasing pathways were open when building our models. So we respected this as we built our models. And to make a long story short, in terms of recruitment, you had, 464,000 births in BC over the period, 141,000 in Manitoba. And then once we'd done with our exclusions, which were mostly lost to follow-up, because kids move around a lot in Canada. We were down to 342,000 in BC and 133,000 in Manitoba. You'll note also that preterm births were excluded here. That wasn't the question we were looking at. I think it's a fascinating question and one that needs to be addressed in addition to what we've done. So the raw data, you can see that antibiotic use, as we're reporting, has declined in British Columbia among those infants, and overall 36% of them received it. And what's going on here too is that we're sort of going back to simpler antibiotics. Combinations are kind of disappearing for the most part, and that's good. That's in line with guidance. And over time, in both boys and girls, we're seeing a decline in the asthma rate in BC. But overall, of our cohort, 9.4% developed asthma, 0.6% was coded for eczema, and 0.9% were coded for hay fever in British Columbia. In Manitoba, you saw a less pronounced decline in antibiotic use over the time period. You actually see a fairly level overall incidence of asthma and in Manitoba. And of interest, the hay fever diagnoses were much more common in Manitoba. So for those of you who are allergists, good to think about why that might be, perhaps more ragweed exposure. And so when we take a look at the overall odds associated with antibiotic use before the first year of developing asthma by the age of 5, you can see in BC that was 1.64. We also had a significant, though not very astounding, odds of 1.2 for eczema. And this is also taking into account other important factors. And I want to point out that respiratory tract infection is independently important within this model. So it doesn't disappear, and the effect of respiratory tract infection is not fully explained, by the antibiotic exposure. And then we've also got an impact here on hay fever in British Columbia with an odds ratio of 1.4. In Manitoba, much the same story. We had an adjusted odds of 1.55 for asthma, and we had an adjusted odds of 1.4 for hay fever. And the Manitoba data did not allow extraction for the coding for eczema. Most important in this kind of analysis, though, was we had the sample size to do the kind of sensitivity analysis that you really can't do in smaller cohorts. And the first thing we did was we decided we were worried about confounding by indication. So the first thing we did is we look at only infants with no record of respiratory tract infection in the first year. And lo and behold, even without respiratory tract infection, we've still got the same order of magnitude of odds, 1.8 in BC, 1.6 in Manitoba, in kids with no record of respiratory tract infection in that first year. The flip side of that is to take a look only at the infants with at least one record of that in the first year, and you're still seeing similar order of magnitude, 1.5 odds in both BC and Manitoba. So while we're not discounting the importance of infections, we do not believe that infections are explaining the entire antibiotic effect. Then you can take a look at the timing of antibiotic use by quarter in the first year of life. And you can see that overall, we're seeing higher estimated odds with exposure in the first 3 to 6 months than a little bit later on in childhood. So that goes with the global observations from the meta-analysis from Switzerland. And it fits a little bit with this hypothesis of disrupting microbiota being more serious earlier in childhood. If you're worried about reverse causation, you can do things like exclude infants with a record of viral wheeze, recurrent wheeze, or bronchiolitis from the analysis. And when you do that, you're still seeing a significant effect of the antibiotics. So you can't explain antibiotics away entirely by reverse causation either. We have a couple of more sensitivity analyses. We're still cooking related to likelihood of breast milk exposure and also to disease trajectory. It's important to point out that not every kid has the same trajectory of asthma. And we have kids who have no asthma or at all, sort of like the blue line here. We have kids who develop early onset and chronic asthma that just keeps going. And we have kids who have a more transient picture where they develop asthma and then things seem to wane down within just a few years. So we want to take a look to see if these associations are robust across those trajectories. So let's summarize. In this population-based cohort, 600,000 Canadian kids, we have 64%, 17, and 42% higher adjusted odds of the outcomes of asthma, eczema, and hay fever in antibiotic-exposed infants in BC. That's echoed 3 provinces over in Manitoba, with 55 and 42% higher adjusted odds of asthma and hay fever in antibiotic-exposed infants there. The association with asthma is robust in children only receiving antibiotics for non-respiratory infections. And I know there's an analysis within the child cohort that's trying to tease out the same sort of thing. And children receiving their first antibiotic earlier in infancy had higher odds of developing asthma. And we think that the association with all atopic outcomes that were examined somewhat supports the hypothesis that the mechanism is immune regulated and influenced by gut microbial dysbiosis early in life. I did want to spend a bit more time on this question of confounding by indication, because although the microbiota story is well accepted in microbiology circles, I think people within public health circles and respirology have been fairly critical of it based on this impression of confounding by indication. But let's talk about that a little bit. We've actually seen declining asthma in Canada as well as in those European countries over 20 years in the absence of major declines in viral respiratory infection. In other words, we saw them going down to 2019 before the pandemic, and we had not really done much to impact the overall incidence of things like RSV in Canada yet. The cohort analyses that we're talking about have stratified by or excluded those who got antibiotics for resp infections, and we still find a robust association. So through stratification, we're able to still find the effect. Structural equation modeling in child cohort does suggest that the impact through the microbiota is a more likely pathway for damage than sort of a direct effect. And I will show you one slide. We've actually got experimental studies in mouse models. We can't really experiment on kids and say, oh, we give them antibiotics or we don't give them antibiotics, because we could do a lot of harm that way. But you can do that in mice. And those studies show mitigation of asthma risk by returning protective bacterial flora. And these are in experiments with no respiratory tract infection interference in closed labs. And finally, we do want to address this more comprehensively with future research, like within the child study, for example. One of my colleagues is working with a viroscan serological test. And so this is a test that allows the interrogation of exposure to many, many viruses over the course of the first year of life as detected serologically. So the mouse model of asthma, I just want to tell you a little bit about. I mean, a lot of this whole area came down because people discovered that germ-free mice were getting atopic disease way more easily. And so what Mary Claire Arrieta, she was at UBC at the time, but she's now in Calgary, did was she took these asthma-prone mice and she gave them the microbiota of kids who developed asthma, and lo and behold, in the middle panel, they definitely got a lot of inflammation as evidenced in the lung tissue. But when you gave those that same group of mice the missing taxa that were discovered to be diminished and probably important, that seemed to be substantially protective. So you got a mouse model that shows that this may be at play. And so to conclude, leading up to talk, I think what we're saying is that a significant fraction of the decline in asthma incidence observed over the last 2 decades may be an unexpected dividend of prudent antibiotic use and also higher exposure to human breast milk. The next steps in sorting this out, in our view, are antibiotic class-specific effects. And I can tell you that Hannah was just in touch to say that macrolides seem to have a bigger impact on asthma risk than aminopenicillins, both of them significant. But this is pretty important because people want to use macrolides on mass treatment in many places around the world in order to reduce burden of infectious disease. We do want to explore in other populations. So when we were in the UK, there's a data set in England that covers about 1/3 of the population. So we're working with folks at Imperial College and UKHSA and University of Liverpool to do a similar analysis to the one that Hannah did on Manitoba and BC stuff. We also want to follow work on other cohorts around the world that are informing what's going on. So child investigators are very keen on those collaborations. We want to think about knowledge translation, and I really want your take, because antibiotic stewardship and breastfeeding were kind of good ideas even before this evidence. So who needs to know? What difference does it make? And how can we move on? Does it provide a more compelling case to fund Dr. Schwartz for antibiotic stewardship in Ontario? And we also want to think about those kids who need to have antibiotics and can't be breastfed. And what does this mean for intervention trials of prebiotics that might contain human milk oligosaccharides, and probiotics and symbiotics for kids who need antibiotics? And we also want to consider the implications and relevance for low and middle income countries. We're seeing asthma rates on the decline in much of the north, but things are going the other way, where people are moving to cities, having more access to antibiotics and more access to pollution. And we're wondering if this is going to be an important factor in most of the world's population. So I'll leave this sort of with a meditative summary haiku, which is an overly simplistic summary, obviously, but I sort of just like to leave things simple: reduce asthma risk, avoid antibiotics, foster breastfeeding. So with that, I'm really keen to get your questions because we want to examine this from every possible angle. And this is a hypothesis that we're keen on investigating, and any help with falsifying it is also good.
Thank you. Thank you, David. That was fantastic. Um, at this point in the presentation, we're going to move on to the Q&A segment and address questions from the audience. Please continue to enter your questions into the Q&A pod if you've not already had an opportunity to do so. I think while people are thinking of their questions, I have a couple that I can start off with. I think what struck me was just, there's a lot of work around the microbiome, and I think our technology moved very quickly in terms of characterizing the microbiome, and often we're not necessarily attaching it to real clinical outcomes. So I think what's interesting in this is that we're making the connection right off the front that there's microbiome changes also associated with important clinical outcomes. My my question is about just also the next steps. Have you thought about looking at dose response effects? That is, that what if kids get 2, 3, 4, 5 antibiotic courses? What about the kids that are on chronic antibiotics for prophylaxis for UTIs? Like, are we seeing some dose response in this sort of perturbation of the microbiome that would then lead to real higher increased risk of asthma? And you think that would help the case as well in terms of this reverse causality issue?
Yeah, no, Kevin, we're very clearly seeing a dose response in most of the work that is relating antibiotics to asthma risk. In the meta-analysis, it was fairly clear there was a dose response. In our original study of child study, I put up a slide that showed that was a clear dose response. You increased your risk with one course, but the risk was increased further with more courses of antibiotics. And that showed up in spades in the BC and Manitoba birth cohort data. So there is a dose response risk. For the most part, the risk is very clear with the commonly used antibiotics in infants like amoxicillin and azithromycin. The only place where the risk didn't seem as high, to sort of refer to your UTI prophylaxis thing, is that trimethoprim sulfamethoxazole didn't seem to do quite as much damage in some studies to microbiota, and I'm not exactly sure why that is. A few studies showing that.
Okay, great. I'm going to take a few questions from the Q&A box. You can continue to ask your questions as well. So the first one, David, did you look at any breastfeeding versus exclusive breastfeeding related to the risk?
It depends on where you take a look at things. I mean, the breastfeeding versus exclusive breastfeeding is a really interesting question, first of all, because I think most of our advice and measurement of breastfeeding has been around exclusive breastfeeding. For this mechanism, it seems that the human milk oligosaccharides are important, and there's no a priori reason to think that exclusivity would be critical for this benefit of breast milk. So within the population-based studies, it's really hard to get accurate information on breastfeeding within the cohorts because it's not recorded in any of the administrative data sets. So we've been actually developing a predictive model using child cohort data to say which variables predict any breastfeeding up to 6 months, and trying to apply that back to the population-based cohorts. That's why that sensitivity analysis wasn't up just now. But mechanistically speaking, it's probably the HMOs, whether exclusive or not, that would be beneficial here. There may be other reasons to recommend exclusive breastfeeding for a period of time. The other thing our Irish colleagues found, though, is that weaning is kind of important, and they're finding that certain foods upon weaning do a better job of promoting that second wave of beneficial fermenters, particularly nut exposure, actually. And so we're kind of interested in where that plays out.
Great, thank you. Another question, has anyone looked at intrapartum antibiotics, like for GBS prophylaxis and association with that in asthma?
Yes, there's been a few really good reviews globally on that, sometimes alone and sometimes alongside postpartum antibiotics. And what you do is you routinely see an impact of that, slight increase on atopy, certainly a risk of increased perturbation of microbiota, but not on the same order of magnitude as when an infant is given systemic antibiotics, whether oral or IV. There, it seems like the effect on the microbiota is even more direct, and the impact, the odds associated with that risk are much higher than what you see with intrapartum.
Thank you. Um, I did have another question. I mean, I guess any thoughts about, future therapeutic trials? Like, do you think there would be a scenario where, a child needs antibiotics for whatever reason, that we would also be trialing some sort of, biotic cocktail, fecal, mixture sort of pills, liquid to babies to try and mitigate this risk?
Well, I'm thinking that this kind of work, and obviously that, as you were hinting in your first question, everybody's looking for the microbiota in association with everything, and we really do want to see good epidemiological studies, prospective studies, and experiments and trials that show the benefit, because a lot of what we're seeing is cross-sectional, and so we can see association with your favorite disease, and that goes on. But yeah, so we do need to sort of think about whether these data allow for more intelligently designed probiotics, as we might call them. If we know that Bifidobacterium infantis is key in the first 6 months of life, and there's another dozen species that do really wonderful things in the second 6 months of life, it makes sense to design interventions around that. But also, it seems that the human milk oligosaccharides are really important. They don't feed the baby, as I've mentioned. They feed the beneficial bacteria. We've co-evolved with milk as a food. It's the only food we've co-evolved with so intimately, that you need that prebiotic component to be considered. And so, in a kid who needs under the age of 1 who needs antibiotics, I think it's going to be a very important area, especially a kid who can't be breastfed for a long period of time. It'll be critical. But it is important to point out that this effect we're talking about in infancy for atopic disease is sort of a time-specific effect, that we take a look at antibiotics later in childhood, and they're having much less association, at least with atopic outcomes at that point. So we think it's how we're influencing the set point of the immune system. So it wouldn't be all kids. It would be probably focusing on infants.
Thanks. All right. Another good question here, I think. So, any information or data that you're aware of that compares vaginal birth versus C-section in relation to both the microbiota changes, but also atopy risk?
Yes, that's very well documented, and we can see in the asthma papers that you see an increased risk in babies born by C-section, particularly C-section without trial of labor, compared to those born vaginally. So that risk is there, and there have been many a microbiota study that has suggested some degree of delayed colonization in children who were born by cesarean section, to the extent that there have also been studies about whether you can restore that exposure for the kid by taking a swab from the mom or providing a probiotic postpartum.
Another one that I know there's a lot on this in the presentation, but I think about the reverse causality. And so in this question, they give an example: a child has whooping cough and treated with antibiotics, recovered, and then develops and diagnosed with asthma shortly after. So how do you disentangle it? Was asthma caused by the antibiotic they received, or the infection that they received the antibiotic for?
I think that has been the key question, and it's one that I think has been very fair game. But as per that slide I showed, I think there are 5 or 6 reasons why we can't dismiss this effect as confounding by indication or reverse causation. Those sensitivity analyses that I showed you were part of that explanation as to why we feel that way. But the other side of the equation is that we are pretty sure that breastfeeding is good for a variety of different reasons, and that avoiding unnecessary antibiotic use is good for a variety of important reasons, including reducing AMR risk. So I think maybe even if we have doubt, or there are elements of this audience that have doubt about this causal relationship, that wouldn't be an argument against more concerted efforts to advance those two methodologies for preservation of health.
Another one about I think about older children or adults. So, is asthma an antibiotic-associated adverse event at later stages in life as well? When thinking about the cost benefit of antibiotics, should we always be thinking about asthma as an adverse event?
No, I'd say not. What we're finding is an effect that's very clearly important in the first year of life, maybe in the second to an early degree, but the first 6 months of life, very much. The second 6 months, pretty important. After that, tailing off quite a bit. So this doesn't necessarily need to factor into your calculus on treatment of older kids very much. I think we should look to learn more about how the microbiome can be affected and how it can relate to other illnesses. We're in an environment now where people are trying to connect the dots with, inflammatory bowel disease, with various neurological conditions, all sorts of things. We have lots to learn in that regard. The only thing that's pretty clear out of our studies is that time-limited risk in the first year of life.
Thank you. Thank you. Um, all right, let me see if we have time for one more question. So, looking at the graph you use about different bacteria classes post-birth, can you talk more about the way in which different bacteria might interact with each other? For example, if one bacteria's class's growth dynamics is disrupted, does this affect the growth of the subsequent bacteria?
That's a great question, and one, that I think would take a whole variety of other talks, but probably the most important association that we should talk about is that initial bifidobacterium peak, where if you get bifidobacterium longum subspecies infantis fermenting human milk oligosaccharides and creating acetate, that environment is felt to be very conducive to the secondary bloom of the fermenters that come later, that replace that function. So where you've had the acetate production by B. longum, by B. infantis, you get all these secondary fermenters coming in. That was very clear in Darlene Dye's analysis of the breastfed versus not breastfed babies and the perturbation from antibiotics. And it's also seems to be well reported among other studies that take a look at the succession of different types of bacteria in the gut in the first year of life.
Thank you. That was really, really fascinating talk. So I'm gonna wrap things up for today. I just want to really thank Dr. David Patrick for joining us and presenting, and all of you for joining today's webinar. If you're going to receive a survey from PHO, please fill it out as it helps improve the programming. If you requested a CME letter, please be patient, and you will receive it in the coming days. And lastly, if you want to access the presentation, it will be available online in the future. Just visit the PHO website, go to Education and Events, and click on Presentations.
And Kevin, if I may, for those of you planning public health or thinking about implications like this, feel free to write to me, david.patrick@bccdc.ca, where we've done these studies and we're interested in how they're resonating throughout public health and what their implications should be.
Excellent. Well, with that, I want to thank everyone again for joining, and have a wonderful day.
Thank you.